So my talk is about the central cord syndrome. Those are my outlines for the presentation. The body of the literature is quite large for this topic, so there is a variation in the evidence, and there is a lot of controversies that I thought is going to be a little bit interesting to go through those in my presentation. So traumatic spinal cord injury is a very devastating event to the patient. It poses a lot of challenges to the healthcare, to the physician and also the healthcare system. And the magnitude of the functional impairment following spinal cord injury is classified based on the preservation of the neurological function below the level of injuries, which is mainly classified into a complete and incomplete spinal cord injury. So central cord syndrome is the most commonly encountered incomplete subtype. And it's mainly resulted from a traumatic event, although it can be caused by a tumor or syringomelias. So McKinley, he reviewed almost 800 patients with a spinal cord injury and found almost 20% of them are presenting with incomplete subtype. And among those, 50% of them are labeled as a central cord syndrome. So the incidence in the US is reaching almost 11,000 cases per year. Unfortunately, we don't have the data in Saudis. We lack the national registry, so most of the data are coming from a central or a single centers. Like there is a paper published by a group in the military hospital in Riyadh reporting the incidence to be 2.1. Acute traumatic central cord syndrome was first introduced to the neurosurgical literature by Schneider and his group. That was in 1953. This is a very interesting paper that I prefer to spend a few minutes talking about it because it established the definition of central cord syndrome. The management had a huge impact on the management for a few decades after the publication. So I pulled this quote from his paper. He said, in acute spinal cord injury, there is a syndrome that suggests central cervical spinal cord involvement. It's characterized by disproportionately more motor impairment of the upper than the lower extremities, bladder dysfunction. The lower extremities tend to recover motor power first, bladder function return next, and finally strength of the upper extremities reappears. So pretty much what we know up to now. So what he did is that he reviewed 9 cases of who exhibited symptoms of central cord syndrome. And the first case, which is classical of what we all heard or seen with a central cord syndrome, a 65-year-old man, he was tripped on a rug and fell directly over his face. He had like a sort of hyperextension injury to his neck. So he developed a paralysis and numbness in all extremities. And after 5 days of the injury, he regained some of the neurological function. They did an X-rays and they found like a spare at the level of 4-5. And also they did a Milo where it showed discontinuation of or complete block at the level of C4-5. So they took the patient 10 days after the injury and they did a cervical laminectomy at 3 levels. And then they went and did a dural incision. And they sectioned the dentate ligament. They found out there is an anorectiditis at the level of C4. Unfortunately, the patient didn't do well after the procedure. He deteriorated further neurologically, and he passed away a few weeks after that surgery. So based on that, Schneider and his colleague, they concluded that surgical intervention is contraindicated for such a syndrome. And that's based on 3 reasons. Reason number 1 is central cord syndrome. Patients are more prone to have a spontaneous recovery as a natural history of this disease. And in their postmortem and cadaveric study, they showed that there is a widespread edema. There is no local area to be decompressed surgically. And also, they found that the surgical exploration in their hands further disabled patients. So their paper had a huge impact on the management of central cord syndrome. And for almost, like as we can see in this slide, for almost 3 decades, conservative management was the approach for managing those patients. Until in 1984, Bose, he reported almost 14 patients who came and presented with a central cord syndrome. It was a mixed sample. Some of the patients were having fractures, while others is having only spondylosis with a hyperextension injury. And he identified that 14 patients of those patients who were operated, they did well after the surgery. They didn't deteriorate, in contrary to what Schneider was reporting, even though they had a greater functional recovery at the discharge. So the flow of the surgical intervention and the publication proceeded that, and Chen in 1998, he again studied 37 patients with cervical spondylosis. They were treated with central cord syndrome. So patients who failed to improve by one motor grade after the injury was taken to the OR, and with a mean average of 9 days. And he showed again that patients who underwent surgical intervention had a quicker motor recovery and decreased length of stay compared to the patient treated conservatively. Although at 2 years, there was no significant difference between the two groups. And many studies shows the same conclusion. Orby, he reviewed 29 patients with only hyperextension injury, and he found out that taking the patient to the OR will have a high chance to improve their ACS grade at 3 months. So I think we agreed that the patient treated surgically have a shorter length of hospital stay, as also they would have a quicker initial neurological recovery compared to the patients who were treated non-surgically. However, the long-term follow-up has failed to demonstrate any significance between the two groups who were treated conservatively and surgically. So how about the time of surgery? Is it early or delayed? A lot of paper was investigated the timing of the surgery, and one of them was published by LeRose in 2014. It's a systemic review meta-analysis to investigate the timing of the decompression and taking the patient to the surgery. So the patient with acute spinal cord injury who underwent early surgical intervention had a superior outcome compared to the patient who underwent a delayed surgical intervention. Another study that was published by Guest, it was a retrospective cohort study of 15 patients. He divided the patient into two groups. So based on the mechanism of injury, so in the first cohort is the patient who had a trauma ended up with fractures or disc injury, and the other group is a patient who had only a hyperextension injury without any fracture or instabilities. And then they divided them based on the timing of surgery, on less than 24 hours or greater than 24 hours. And he showed that the patient who came with fracture or instability doing a surgery in the less than 24 hours would improve their neurological recovery. Although the timing of surgery for the other group didn't demonstrate any affected motor recovery. One of the recent also studies by Prof. Felling in 2022 investigating the early versus late surgical decompression for central cord syndrome. It's a matched cohort study for almost 186 patients from 1991 to 2017. And the primary endpoint was motor recovery at 1 year. And as we can see that the early surgical decompression group, they have an associated with significant recovery, statistically higher at 1 year in comparison to the patients who were taken after 24 hours. Also, some paper, they contradict this rationale and showed that taking the patient early or late wouldn't significantly impact the outcome. So I thought in the next couple of slides, I'll speak about some of the mediators that might mitigate the outcome of this syndrome. So in terms of the pathophysiology of this disease, like it's spinal cord injury goes through different phases, primary and secondary. Primary would last for a few seconds, and it's where the energy is transferred to the cord, and it's somehow irreversible. Although the secondary, which might take up to weeks to months, it's a sort of interaction at the level of the cellular and inflammatory level. And it starts with a vascular disruption, going through ischemia and upregulation of the inflammatory markers, ending up with a cell death and glial scar formation. All of our interventions are targeted to manage or to manipulate or mitigate the secondary phase. And we know for a fact that blood flow to the cord had a detrimental effect on the neurological function, and that's on preclinical studies, although the efficacy of augmenting the blood pressure after the injury is not yet clear in the literature. Many studies in the early 90s by Vail and his group showed that there is an improved neurological outcome if the MAP was kept above 85 to 95 for 5 to 7 days. Also, Harlick, he published a paper where he reviewed 100 patients, and he confirmed, or he showed that patients who maintained the blood pressure above 85 with a less proportion of dropping below 85, they would have an improvement in their ASIA score by 1 grade in comparison to the others. So despite that, we still lack the evidence about the patient's actual blood pressure to conclude or to draw that conclusion. And we cannot establish the relationship between improving the blood pressure and the neurological improvement, because there is a lot of co-administrated intervention given at the same time. Although the current recommendation of the American Association of Neurosurgeons and Congress of Neurosurgeons is to avoid hypotension. Methylpred, it has been extensively studied for spinal cord injuries and central cord. And NASCIS, which is the landmark paper, proven that those patients might have a motor improvement when the steroid is received within 8 hours. Also, it has been criticized both because of the post hoc time and the 8 hours time frame. And other papers contradict that conclusion and showed that steroids doesn't have any direct impact on the neurological recovery in spinal cord injury, although it poses a lot of side effects. One of the recent papers that was published again in 2023 about the use of methylpred in acute spinal cord injury. It's a systemic review, and the conclusion that was drawn from this paper is that methylpred failed to show any statistical significance in a short or long-term neurological recovery. In 2013, the Congress of Neurosurgery issued the level 1 recommendation against the use of methylpred. And AO Spine, although they suggested the administration of 24 hours methylpred according to the NASCIS 2, and they didn't have any update about that recommendation. But the other societies are against this recommendation, and they are showing they don't recommend giving methylpred for those patients. So because of that, there is a drop in the usage of methylpred in spinal cord injury to almost 50% from 90% in the last 10 years. One of the medication, I'll go through it, is the Riluzole, which is an anticonvulsant sodium channel blocker that was approved for ALS. It showed some potential benefits for the patients with spinal cord injury and central cord injuries. And it has been extensively studied by Prof. Fehling. Also, in his latest phase 3 study that was published in 2023, the primary analysis didn't show any efficacy of Riluzole on spinal cord injuries. So in conclusion, understanding the acute traumatic central cord injury has evolved in the last 15 years since the paper of Schneider. And surgical intervention for the appropriate patient is associated with aerial improvement and shorter hospital stay. Each patient with acute traumatic spinal cord injury should be evaluated on an individual basis, and further research is needed to strategize the treatment. Thank you.